Hello, everybody. Thank you for joining us for the April RDLA webinar. I'm going to give everyone just a little bit of time to get logged on, and then we will get started. Awesome. Thank you guys for joining us. People will continue to funnel in, but we're going to go ahead and get started. Like I said, this is our April RDLA webinar, and we are going to be focusing on the ending of the COVID-19 public health emergency and the implications of the public health emergency ending. If you prefer to call into today's webinar, you can do so using the phone number and webinar ID on the screen. As our lovely panelists are speaking, if you have questions, please type your questions into the Q&A box, and Shannon or myself will direct your question to the speaker. And just a reminder, if we have any media joining us, we ask that you formally announce your participation and refrain from quoting any of the discussion during the webinar. We encourage you to follow with participants afterwards to use direct quotes. And we also have closed captioning available for this webinar. So if you're interested in using that, you can click the live transcript button at the bottom of your window. And we also have Spanish translation services available. So you can access that by clicking the link that Shannon just posted in the chat for everyone. So this is our agenda for today. We are joined by Nisha Kusaba from Fager Drinker Consulting, Eric Gasho from the National Health Council, and Galila Salasi from Justice in Aging. Each of them are going to talk a little bit about different pieces of the public health emergency unwinding. And Galila is going to talk a little bit more about what Justice in Aging is doing with their advocates and their efforts on educating and notifying their advocates about the ending of the public health emergency. So Nisha, I will go ahead and turn things over to you just to give us a nice overview of the public health emergency.
Well, hi, everyone. Thank you, Caitlin, for that beautiful introduction. Good afternoon to folks. I know on the East Coast, we're just hitting lunchtime and perhaps some are just waking up, depending what your time zone is. So I'm Nisha, as I said before. I'm from Fager Drinker Consulting. A little bit about us. We work alongside actually the Every Life federal team to help further the foundation's priorities, whether it's in front of Congress or FDA and otherwise. You might have seen and heard from my other colleagues. So really excited to be here. For today's discussion, we recognize that we're three panelists. We don't want to be duplicative in our comments and remarks. So I will keep my comments at a very basic level. So what authorities, or in simpler terms, tools of the federal government have to pull in a time of crisis to help basically expedite disbursement of resources, fuel innovation, and temporarily lift restrictions on existing law and insurance policy to increase access to measures that for the period of the emergency were needed and are needed. So the different types of federal emergency declarations, aside from just the public health emergency, and the reason I want to bring the other two up that we will not be going into today, just because those are other ones that have been in the headlines, and I don't want to be amiss of not mentioning them. One that was declared is called a national emergency declaration. It's actually a power that's exercised by the president himself or herself. This declaration isn't health specific. So this has been used in the past to block international activities or address the banking crisis and others. But there was a national emergency declared for COVID-19 by President Trump back in March of 2020. So we're thinking right in the beginning. But after the passage actually recently of a joint resolution by Congress, it actually was ended 10 days ago on April 10th. Actually, prior to that resolution, the plan was for it to expire, the national emergency declaration to expire as the public health emergency is set to expire on May 11th, but actually Congress took a step to expire it sooner than that. So that was one. A second, which is a separate emergency declaration that can be issued by the Secretary of HHS, is the authorization of EUAs. I'm sure that that abbreviation is very familiar to many of you, the emergency use authorization. It's essentially a mechanism that allows the facilitation, the availability of medical countermeasures. So we're talking about lab tests, PPE, medical devices that have been determined to be safe and effective, but have not gone to the formal approval process that typically all FDA products have to go through. It's a way during a time of emergency to get something to the public quick and fast. This emergency declaration was declared back in February of 2020 and remains in effect until Secretary Becerra, so HHS Secretary Becerra, wants to terminate it. So this is also not tied to the public health emergency expiration that's only about less than a month away on May 11th. So going to today's discussion about the public health emergency, which is health specific, as the name kind of alludes to, allows the federal government to release resources meant to handle an actual or potential public health crisis at the national or state level. So when we're talking about state level, think of like assistance for wildfires or hurricanes, earthquakes, or just looking kind of through the past that have happened. But even at the national level, the opioid epidemic is one that's actually an ongoing public health emergency, has not been terminated. And then, of course, the COVID-19 public health emergency, which was declared January of 2020 by the Secretary of HHS at the time. And actually, the public health emergency lasts for 90 days and must be renewed before the 90 days are up, if it's to be continued. It was renewed several times in the past 3 years, I think 12 times to be exact. And most recently, I think the most recent renewal was actually in February. And as I noted earlier, it will expire on May 11th, which is less than a month away. So when declaring the public health emergency, besides allowing the government to provide resources, procure supplies, and give the Secretary of HHS broad authorities, what the federal government did was also give flexibility to several policies. So that means bending the rules a little bit on existing law and regulations. And so what we're going to see is on May 11th, a lot of those flexibilities, as they're commonly called, will come to a close. So not surprisingly, at the beginning of the pandemic, some items that were specifically kind of bent the rules to make it kind of a little easier than call them flexibilities is there was a lot of appropriations and investments in vaccine development, mass order of purchases of various countermeasures, so ventilators, PPE, masks for the general public. There's relaxations of some HIPAA regulations in the healthcare space to allow more products and access to healthcare services during a time when the government or the public was, in their homes. And there's also flexibility, as I'm sure you've heard and hopefully have taken advantage of, is access to telehealth, allowing any patient, no matter if they live in a rural setting or not, to be able to access their healthcare provider from the comfort of their home. This was quite different, and the utilization of telehealth significantly increased during the pandemic. What I want to talk about is what are we going to see change on May 11th, and what was allowed during the public health emergency and what will come to a close. I know the other two panelists are far better Medicare, Medicaid experts, so I will not go too in the weeds, but cover it very high level. One is public health data collection. So you'll recall CDC and many other entities were funneling and trying to get a handle on the pandemic, meaning needing data, needing to know who and where the cases were to be able to try to effectively supply targeted approaches to the outbreak. With the expiration of the public health emergency, HHS authority to require COVID-19 lab test reporting to CDC will no longer exist, meaning CDC will not have nearly as much data to be able to have to track COVID-19 cases as easily. So that's one. Two is the telehealth world. So many of the tele-flexibilities were actually extended up until 2024. And I will speak specifically that telehealth flexibilities within the Medicare program. There was some one policy that has caused quite the stir is during the pandemic, the remote prescribing of controlled substances via telehealth without requiring an in-person requirement was allowed. Meaning, if you were sitting at home, you were able to receive critical clinically medically needed care that was actually could be given a controlled substance from your home. And you might be imagining, well, why was this such a case? And you can think through a little bit. This is a crucial policy that was needed for many, especially those who suffer with mental health or behavioral health conditions. Many of those treatment plans and many of those therapies are controlled substances. And so when folks are sitting at home isolated, this was a very effective method to ensure that folks were still getting the care that they needed from the comfort of their home. This will essentially come to an end as of today, with no other action from DEA, as stated today, will end on May 11th. There is a proposed rule that DEA, the Drug Enforcement Administration, the agency that actually has jurisdiction over this policy, that in that proposed rule, it actually reinstates the in-person requirement that would be needed for an individual to continue to get a controlled substance through a telehealth visit, meaning that they first would have to be seen in person before being able to be able to get it on a telehealth visit. The proposed rule is currently being finalized, and so we'll learn a little bit more as far as what is changed. But that is one that is to keep an eye on, and you'll probably see a lot of headlines on. Still in the telehealth space is licensure. It's a little bit smaller. During the pandemic, states that had allowed providers to practice across state lines, many of those state flexibilities have been long expired and reverted back to pre-pandemic ways, but there are a few states that tied their licensure flexibilities to the federal public health emergency. So that will come to an end. And I was looking this morning, the Federation of State Medical Boards, so the national organization looks at members of medical boards that basically track the licensure policies. They know that 3 states follow the federal public health emergency. So it's a quite small number of folks that would be impacted. On the coverage of COVID-19 testing and vaccination therapies, during the pandemic, to boost access to vaccines, Medicare waived cost sharing of COVID-19 vaccines, and that will come to an end. There was no cost sharing for COVID-19 at home testing during the pandemic in traditional fee-for-service Medicare and Medicare Advantage, and that will end. And then treatment, including monoclonal antibody treatments, will require beneficiary cost sharing. So that is for Medicare beneficiaries. In the private insurance space, the public health emergency doesn't technically dictate private insurance coverage for treatments. But from what we've seen, most plans will not require out-of-pocket costs for vaccines once they're commercialized. But as a result, I think there's an anticipation that premiums may increase depending on seeing that there will be a cost burden. So that's TBD, not complete under the public health emergency, but something that we've seen in the news. And for those who are underinsured and uninsured, Moderna, so one of the COVID-19 vaccine manufacturers, announced plans to provide free vaccines for those populations. And then for Medicaid, I think this is a perfect segue into the next presenter. Medicaid is a federal state partnership, meaning that states do have a lot of discretion as far as what they cover and what the eligibility is. And so there's too much variation and variety throughout the country. So there's no way to say all in 1 or 2 sentences. So that's why we have Eric on the line, who will give you a great in-depth look as far as what will change for Medicaid eligibles. Thank you.
Great, Nisha. Thank you so much for all of that. It's a beautiful rundown, and you're correct. It is a great segue into Eric's presentation. So Eric, I will go ahead and turn things over to you.
Great. Thanks, Caitlin, and thanks, Nisha, for setting the stage, the wonderful presentation. If we go to the next slide, I'll just give a quick overview of who we are at the National Health Council. I know, if we go to the next slide, please. Yep. I know I've been on these a number of times, but just as a refresher, National Health Council is a membership organization, primarily the patient advocacy organizations that you see on this slide. We are multi-stakeholder in our membership as well. So we have insurers, biopharmaceutical companies, provider organizations, other types of nonprofits, really bringing in the broad perspective from across the healthcare ecosystem, but really driving towards patient-centered policy solutions that impact all people with chronic diseases and disabilities, both rare, more prevalent, and kind of everyone in between. So this is a perfect topic for me to be talking about, because I know the Medicaid program is very near and dear to all populations within our membership and everyone with a chronic disease or disability. So if we go to the next slide, we already kind of got a lot of the PHE background that you see here. One thing I do want to mention before diving into Medicaid, certainly, really appreciate a lot of what Nisha mentioned about the telehealth flexibilities and how we have extended some of it, but we'll see some changes at the end of the PHE. One thing I do want to also mention that's not included on this slide as well is she mentioned the emergency use authorization products, and I think there's going to be a lot of work with FDA in terms of a lot of the flexibilities that they were granted, some that will probably continue and turn into existing policy. There are a lot of lessons learned in terms of how drugs are brought to market that could potentially be very useful in terms of remote clinical trials, et cetera. But one thing to really make sure I want to drive home and sort of reiterate is that the emergency use authorizations, or the vaccines and treatments that are still authorized under them, will continue to be available to people as they think about going for full approval. So a lot of work to be done at FDA as well, but certainly want to make sure I spend most of the time talking about Medicaid today. So I think we already got most of this background. I think the sort of key thing within the Medicaid program, actually, if we go back one slide, I apologize. The key thing within the Medicaid program to understand sort of where we've been, to better understand where we are today and where we're heading, is that under the public health emergency, and then soon after that with one of the first COVID relief bills, Congress and the administration did a really smart and important thing, which was really support the Medicaid program, knowing that a lot more people were going to need access to healthcare in the middle of a pandemic, and also at a time where we saw a lot of folks losing their employer-sponsored coverage and really needing to utilize the social safety net of the Medicaid program. And so a couple of things that were put into place that are really important. One was that the federal government agreed to pay more money to the states to fund their Medicaid programs. You might see the acronym FMAP throughout my slides. Not important to know what that stands for. Important to know that this is additional funding that went from the federal government to help the states to be able to cover their citizens under their Medicaid programs. Secondly, and very importantly, is that in order to receive this funding, states had to agree not to disenroll anybody from their Medicaid programs. And so a lot of folks joined Medicaid at the beginning of the pandemic and throughout the pandemic, who are currently enrolled and were not able to be disenrolled until after the PHE ended. And then we'll talk a little bit sort of how that was then delinked and kind of where we are today. If we go to the next slide. So this one gives a quick snapshot of how much growth we saw in Medicaid and the Children's Health Insurance Program throughout the pandemic. We are now at record lows of uninsured rates, which is fantastic. And you see here that much of that was driven by record enrollment in the Medicaid and CHIP programs as well. So the great news is we've had more people than ever have health insurance coverage, but now we need to make sure that people maintain their coverage either through Medicaid or through other programs, as well as we're coming out of the pandemic and looking at a very different scenario. So if we go to the next slide. So as I mentioned, the Medicaid continuous enrollment requirements are no longer tied to the public health emergency. So at the end of last year, in the end of year spending package, Congress did a couple of things related to the Medicaid program and related to the continuous enrollment. One is that it is no longer linked to the public health emergency, so it established its own timeline for what is known as the unwinding, or the process that the states are going to go through of disenrolling people who are no longer eligible for Medicaid. So as of April 1, states were able to begin going through that process. I hopefully am not out of date with this, but last check, 5 states have said that they are going to start that process. Those states are Arizona, Arkansas, Idaho, New Hampshire, and South Dakota. Have all said that they are going to begin that process. Also requiring the states, as they do go through this process, they have to submit monthly data to the federal government. And if they don't, they will face a penalty, again, with that additional funding that the federal government pays to the states. Also importantly, it requires 12 months of continuous enrollment for all children who are enrolled. So as we go through this, you'll see why this process is going to look a little bit different for adults and children because of that as well. If we go to the next slide, this one just shows that this is not all going to hit at once. There's going to continually be additional funding from the federal government throughout the course of the year, but that will ramp down. So you'll see it's a big reason why some states have not started the process, but will by the end of the year. A, they're required to, and B, this will be a little bit of an incentive for them to begin that process, as well as these numbers start to ramp down over the course of the year. Let's go to the next slide. So there's also additional requirements put on the states as they go through this, the unwinding or the disenrollment process. There are a number of requirements that the federal government has put out in terms of the renewal process. There is a requirement that they have to make all efforts possible to update any of the enrollee contact information. This is going to be really important. You hear a lot of work that Justice and Aging is doing on really making sure that people have the information that they need. Not able to have more restrictive eligibility and enrollment standards. So really making sure that this is done as a process that's really trying to find the folks who are no longer eligible and disenrolling them, but easier said than done, as we'll talk about here as well. If we go to the next slide, as I mentioned, there's also going to be a requirement that there's data reported, and the hope is that this will be very usable for the advocacy community to really understand where the challenges have been and really work within their communities to help rectify some of these changes and make sure that the people that they serve are getting the information that they need. We go to the next slide. So just a couple predictions that have been out there. I think these are all things that are not entirely knowable, but this does show the scope of what people are expecting to potentially happen throughout this process. What we're certainly looking at the millions of folks who are at risk of losing Medicaid. I do want to highlight, and when I go to the next slide, you'll see kind of the numbers put on this as well. But there's sort of 2 buckets of folks that we really need to be focusing on as a community. There's those who are going to lose their Medicaid coverage because they are no longer eligible. Folks maybe came into the Medicaid program early in the pandemic, their income has raised, they are no longer actually eligible for the Medicaid program, and for many of them, they will be eligible for other financial help, so potentially subsidies for ACA marketplace plans. So for those folks, it's going to be really important that we are making sure they know what they need to do to get into the marketplace. There's a special enrollment period that's been open for people who are disenrolled from Medicaid to be able to get into the marketplaces. So that's kind of one bucket of people. The other bucket are those, and these are the ones that I think we're most concerned about, is really folks who are still eligible for Medicaid, but are not able to re-enroll. So, some of these folks may be people who have moved and have not updated their mailing address and do not know that they need to be enrolling for Medicaid to be re-enrolling. A lot of these people have probably never gone through this process before. This used to be an annual process, but we haven't done this in 3 years. So for a lot of people, this will be an entirely new process for them. So it's really beholden on all of us. This has been one of the most all hands on deck approaches that I've ever seen, to make sure that we are getting people the information on what they need to be doing now and what they need to be preparing for in the near future. If we go to the next slide, so this was a prediction by the Assistant Secretary of Planning and Evaluation at the Department of Health and Human Services that was predicting who might be most at risk of being disenrolled, either because they've lost eligibility or for procedural reasons. So those are the folks who, for example, haven't updated their mailing addresses. And it's not too terribly surprising, but incredibly disheartening to see that the folks that we think really are at the most risk of being disenrolled despite being eligible are people from communities of color. Particularly those with limited English proficiency. We see a huge risk there of folks getting the information that they need and doing what they need to be doing. You'll see also, when you look at this from an age band, remember earlier that I said that children are still eligible. And so there's a really concerning potential here that folks who are still eligible are not aware of that and doing what they're needing to do. One example that we've heard a lot of is that you may have a parent and parents and a child who are currently in Medicaid and or CHIP, where they will get the renewal notices in the mail. And it may actually be that the parent is no longer eligible, but the child is. And so really making sure that they know that there's differences of eligibility between them and their other family members is going to be really important, but potentially very difficult to message. If we go to the next slide, and this just kind of reiterates what I just mentioned. I think the people that we're most concerned about really here are people of color, children, those with housing insecurity, people in rural communities with limited English proficiency, those without internet access, certainly those with chronic conditions or more complex medical needs. So, and again, the folks who have never gone through the renewal process as well. So I think we really need to be ensuring that everyone is a part of this conversation, but these are some of the ones that we in the community are most concerned about making sure that we're reaching. If we go to the next slide. So just a couple of key deadlines. Again, April 1 was the date that states were able to start the process. May 11th, as we have heard, end of public health emergency. By July 1, states have to begin the process. So you'll start to see all 50 states be going through this. And then at the end of the year, the additional funding from the federal government will go. And all this has to be done by May of next year. If we go to the next slide. I'm really excited to hear from Galila next. I know she's going to talk about the work that Justice and Aging is doing, but I'll also say that we've been doing a lot of work with other organizations as well to really make sure that we're getting out the word. This is a couple of things that the Georgetown University Health Policy Institute has highlighted as potential things that we should all be looking out for. We have heard from people at HHS that they are certainly interested in hearing from the community how the processes are going in various states. But what they don't think is going to necessarily be very useful are just anecdotes like, my aunt had a hard time enrolling and not even knowing what state that we're talking about. But really what they need is more aggregated information from the community. So to the extent that you all are listening to people who you represent and that are are letting you know about challenges that they had through this process. These are a couple kind of things that we in the community are tracking. Are people receiving their notices in the mail? Are they getting the assistance they need to enroll? How is the process going in terms of wait times? What are the available avenues for renewal? Can they do it online or does it have to be on the phone or in person? Why are people terminated? Is it because they weren't eligible? Is it because they was an administrative issue? So those are some of the things I think we're really tracking. One other thing that I would also highlight on this one as well is I think we really need to think holistically across the country about what this process is going to look like. I think you see the list of states that have already started the process. I think some of them are a little more eager than others to start the process and get people off of the Medicaid rolls. But even those that are, the ones that typically have a more robust Medicaid program and really, it's not a red state versus a blue state issue entirely, because some of even the blue states that have, expanded Medicaid that really put a lot of resources into the program may not have the computer system set up in place. They may be using, outdated data. So there's going to be challenges, I think, across the board, across political affiliations, across sort of how states typically view their Medicaid programs. And this is something that we really want to make sure we're doing across the country. With that in mind, if we go to the next slide, we can skip to the one after that as well. Do just want to highlight a couple of resources that are available. Medicaid.gov has some really great pages on their website. They have some that are geared towards stakeholder organizations and advocacy organizations. They have some that are geared specifically to enrollees and consumers. And I think that one does a good job of linking people to the states that they're in so that they know what the process will look like in their state. So I would certainly encourage people to see what's available there as well. I know we've been working with Unidos US, which has great Spanish language resources as well. So that's another one I'd highlight. If we go to the next slide. Another one is Georgetown University has a tracker on their website that shows which materials have been posted in which states on this process of all the things that states are required to have publicly available. This helps us kind of keep track on where the various states are in the process of getting those up on their sites. And if we go to the next slide, the good news is those two and a whole bunch of others are currently available on our website. Once I'm done speaking, I can put the link into the chat to this as well. But we've been working with our members and with HHS and others to really make sure that we're putting all of these things in one place. So whether it be things that either you're looking to learn a little bit more about the process, or if you are looking to find resources for your patients. We've got them up here, always adding more. Certainly folks on the line have anything that you put together that you've seen that's not on here, please feel free to reach out. Happy to add it. We really wanted to make sure that this is a usable resource for our members and the patient advocacy community to have a one-stop shop for all of the important things that folks are putting together. So with that, one other quick thing. I'll just skip this one. If we have time at the end during Q&A, I'll mention some of the things that are going on the Hill on the Medicaid program more generally, but I think it's important to hear from Galila on the work that they're doing as well.
Awesome. Thank you so much, Eric. We do have one question for you in the chat. The question is, do those that qualify for Medicaid based on their disability also have to go through the redetermination process?
I believe the answer is yes. I will confirm that while I'm on here, but I believe that the only continuous enrollment that was put into place was for children, but I will make sure that I gave a correct answer there.
Perfect. Thank you so much, Eric. Awesome. Galila, I will turn things over to you to share more about what you all are doing at Justice and Aging.
Thank you. Happy to be here. As a quick disclaimer, I think Eric was going to reference at the end something about the Medicaid debt ceiling negotiations, which has been a very unexpectedly time-consuming event this week, and I think is responsible for making me very sick with a frustrating allergies. So apologies if I'm not up to par here. I appreciate your patience and very glad to be here with our other speakers. I'm a senior staff attorney at Justice and Aging on the health policy team. I'm based out of Washington, D.C., and my work is primarily on advancing equity in health policy, and particularly in Medicaid long-term services and support, so long-term care for in nursing facilities and also in home-based care, or HCBS. If we can go to the next slide. And just a quick synopsis about Justice and Aging. We are a national organization that uses the power of law to fight senior poverty since 1972. And we have many subject areas that we do this in. There's the health policy team. We have a lot of economic security and housing work focusing on SSI, Social Security, and food stamps and housing. We have a litigation team, and then we also have a elder justice team as well. And then if we could go to the next slide, we do have a strong commitment to equity that has been going on for a long period of time, recognizing that advancing equity for low-income older adults is really vital to our society. For that reason, a lot of our focus on today's presentation and just moving forward is usually on people who are on the lower income spectrum of Medicare. So my focus will mostly be on dual eligibles. We're not as well versed on things like Medicare supplements or things that tend to benefit wealthier Medicare recipients, because you recognize that the harm is really happening at greater levels to lower income individuals, particularly those at the intersection of race, gender identity, and sexual orientation, disability, economic class, and other historically marginalized communities. And so in order to do that work and prioritize that work, we also recognize that we have to retain a diverse staff. And I strongly encourage you all to join our network. The webinar I'm giving today, or the presentation I'm giving today, is a very small version of one that was given last month that focused a little bit, adds a little bit more about some litigation we were doing, that the deadline for submitting a class has now passed. So I won't be focusing on that as much. And then it also included a bit more on California specific materials, which I will not focus on. But if you do want to access that and our other webinars, you're welcome to join our network. We can move on to the next slide. And so my co-panelists gave really, really wonderful background information on the public health emergency and continuous coverage, so I won't be focusing on that too much. Instead, I will just mostly be focusing on the Medicare and dual eligibles pieces, including I really like Eric's timeline. That's something that I use a lot to sort of navigate everything. So I'm just going to point out some of the specific things that have impacted Medicare and Medicaid dual eligibles, as well as the obstacles facing duals, and then additional practice tips for advocates. So if we can move on to the next slide. There's not a whole lot I need to say here. Eric pretty much touched on everything. One thing I will take note of is that part of that Families First Coronavirus Response Act from March 2020, the bolded, highlighted part there at the very bottom is what folks have been really focused on, and that's the part that says, people must be enrolled regardless of eligibility. Those other three prongs that we kind of refer to as maintenance of effort provisions that Eric mentioned, those are things that are more tied to this May 11th date. And then when I talk about other legislation that was passed during COVID, those other three prongs are really important too. So no premium increases, no stricter standards or methodologies for determining eligibility, and then no cost sharing for COVID treatments. Next slide. This is a very terrible, wonky rule that was the basis of our litigation, so I'm not going to spend too much time on it. But effectively, what had happened is after all this legislation that was really protective of Medicaid beneficiaries was passed in early 2020, later on in the fall of 2020, the Trump administration issued an interim final rule that effectively gave states more flexibility to limit folks in certain categories of Medicaid, so they wouldn't be getting the full scope of benefits. And so where we saw this the greatest was for individuals who are duly eligible in Medicaid and Medicare, or duals, as I will refer to them moving forward. Under this IFR, states could have, if people were no longer eligible for the benefit category they were in, they could be moved to a lower category. So if someone was receiving, say, full scope Medicaid, so they got all the Medicaid benefits, including non-emergency medical transportation, they got Medicaid home and community-based services, all these full scope Medicaid services, as well as all the full scope Medicare services. And then they got Medicaid to pay for Medicare, their Medicare premiums and some of their out-of-pocket costs as well. Well, those individuals under this IFR, some states, and I want to clarify it's not all, but some states were allowed to say, well, you don't no longer meet this income threshold. So instead, we're going to move you into a tier of a Medicare savings program. So instead of getting this full scope Medicaid program, you're only getting a limited Medicaid program benefit that only pays for your Medicare services and your Medicare premiums. It's not going to give you this added benefit there. That was really complicated and very frustrating and confusing. It doesn't look like a ton of states actually acted on this because, as we'll get to, the Biden administration took over. The American Rescue Plan Act was passed, and so it wasn't as monumental as it could have been. But there were some states that were affected, and so this Carr versus Becerra litigation that you might see referenced, but I'm not going to spend a lot of time on, was addressing that issue. We move on to the next slide. Great, and then the only thing I'll mention here is that those three maintenance of effort provisions that I referenced from the earlier slide about the Families First Coronavirus Response Act, those were added to the American Rescue Plan Act. And so what that did is it provided states a specific 10% FMAP, or that federal, basically extra federal dollars for states' Medicaid home and community-based services. And I really wanted to highlight this because for the disability community, HCBS is such a huge lifeline. Excuse me. We also saw during the pandemic all the unnecessary nursing facility deaths and the workforce crisis and the lack of direct care workers and how exploited direct care workers were. And so increasing funds and making sure that people are receiving quality HCBS is really, really important on top of the general coverage, having Medicaid coverage as a whole. So I did just really wanted to flag that. And ARPA is still in effect. States have until, I always miss the date, but I believe it's early 2024 to spend their funds, but I'm going to double check that because I'm on a concoction of allergy meds that makes my brain a little fuzzy. And if we can move on to the next slide, great. And so as my co-panelists alluded to, I mentioned that we do have this uncoupling that has happened through the Consolidated Appropriations Act that basically bifurcated the Medicaid continuous coverage. You have to stay enrolled provisions from the public health emergency provisions that are much more regulatory. And one big point I wanted to clarify here is that while states could not disenroll people from eligibility during the pandemic, there's a fair amount of states that actually sent out renewal forms or eligibility determination forms during the pandemic to sort of just track and just see what's happening, right? Maybe in anticipation of the benefit ending and then COVID ending. The critical thing, though, is that states could send this information out. They just could not act on it. So if someone didn't return it, they could not terminate them, or if they were no longer eligible, they couldn't terminate them. That's a really important distinction I want folks to recognize. And then if we can move to the next slide. So I'm going to spend a minute here talking about some of the actions that were taken by the administration in the early parts of 2023. One big one is that there have been 2 special enrollment periods announced. One is for marketplace coverage, and the other one is for Medicare coverage. And both of these cover individuals who lost Medicaid because of this unwinding process. Because we were just staging, we're a bit more focused on the Medicare front. And so what the Medicare SCP does is any individuals who Medicaid was terminated after January 1st of this year can enroll in this coverage. They can also choose their effective date retroactive to January 1st, which is really critical. So that there's no gaps in coverage if they find out that their Medicaid was terminated and there was a gap in services. The only thing to point out here is because there are some Medicare enrollees who do not get Medicaid, or who do not get Medicaid to cover their Medicare premiums. The people who are not dually eligible, they're only Medicare only beneficiaries. So if someone does choose to have a retroactive enrollment date, it's worth noting that they may have to pay premiums for those retroactive months of coverage, but they will not have to pay a late enrollment penalty, as is often the case with when someone doesn't apply for Medicare right when they first become eligible. So that's really huge. And then if we can move on to the next slide, a couple other Medicare coverage changes. As was mentioned earlier, some of the issues around testing and testing related services. The current policy is that there's no cost sharing for up to 8 over-the-counter tests per month. Lab tests are free under Medicare Part B. So if you actually go to the lab and get the swabs, those are free under Part B. There might be cost sharing for the actual services, not necessarily the test. So maybe like the doctor's fee or something like that to administer the test. And then some Medicare Advantage plans may also have their own additional benefits to provide for additional COVID tests or over-the-counter tests as well. Current policy is that there is no cost sharing for most of the COVID treatments, including antivirals like the Paxlovid, I always get that wrong. And then Part D plans will continue to cover non-FDA approved medications under the CAA, the omnibus package that was passed very early of this year through 2024. So that was a specific carve out that the legislation identified. And then, oh, sorry, I lost my spot. And so when the US government when the supply of Paxlovid and other antivirals is depleted, Part D enrollees receiving these who are receiving Paxlovid not through the federally purchased supply, the Part D plans can pay for that in addition. So that means that depending on the Part D plan, once the supply one runs down, then that'll be determining how much the cost will be. So the cost could effectively vary, particularly for 90-day supplies of this prescription after May 11th. And then the other big things I wanted to highlight is some of the RX, the prescription drug coverage for 90 days will end. Medicare Advantage plans coverage of out-of-network facilities. There was recent guidance that set this to end after 30 days after the PHE. And then it requires similar coverage and protections that would occur under other public health emergencies like natural disasters. And then another big one is a waiver of 3-day hospitalizations for skilled nursing facility coverage. Prior to the pandemic, individuals had to be in the hospital for 3 days with some not under observation status, but actually, well, there's some litigation there, but they had to be admitted for 3 days in the hospital before Medicare would cover any kind of short-term nursing home stay. That was waived. And then this really expanded benefit of what it means to be homebound under Medicare to receive Medicare home health was really wonderful during the pandemic, but unfortunately that will end as well. And then if we can move to the next slide. And then I'm not going to touch on this because I know this was talked about at length by Nisha, but just reminding that some of the COVID-19 vaccines and boosters will be available at no cost under Part B moving forward, as will many of the telehealth expansions through 2024. And then actually, I'm going to ask if you can move on to slide 20, because I know I want to get to questions, and the bulk of these other things were discussed by my colleagues. So I'm going to skip ahead a few slides because most of these slides are touching on things that Eric already touched on about how redeterminations will work. And instead, I really wanted to focus on some of the unwinding challenges that are facing older adults and particularly and people with disabilities as well. Particularly the dual eligible populations. So there are the logistical obstacles that come from a change in address, people moving, people are unfamiliar with the forms. And then I mentioned that Carvey-Becerra case is that litigation regarding the Trump administration rule that came out in November 2020. There was a preliminary injunction. So court, Justice Naging and partners sued on behalf of a class in Connecticut to say that the rule was done improperly and in violation of the American Procedures Act. And because of that, there was a preliminary injunction that said states that did act on that rule had to effectively remedy it by April 31st, or excuse me, by March 31st. So to surpass that March 31st date, we're not, unfortunately, we can't really do anything else in terms of our advocacy there. But some individuals did receive notices from states that said, hey, you get your Medicaid reinstated because this rule that we were relying on was actually wrong. A federal judge determined that that rule shouldn't have been in effect. And then they're going to immediately get notice and say, oh yeah, and by the way, your Medicaid actually is terminated again. So that confusion is really, really complicated. We have a lot of resources on our website explaining what that litigation is about and how to talk to advocates about it if there is some confusion in your state. And then again, the potential losses, particularly for dual eligibles, is really challenging because some of them have lost full scope Medicaid, coverage for Medicare premiums or coinsurance, depending on their income level, and then disenrollment from a particular type of Medicare Advantage program called DSNPs, dual special needs plans. And those are for dual eligibles. And so there's some confusion there. People who are receiving the low income subsidy, or sometimes it's called Part D extra help, should not be impacted by unwinding because that is a purely federal program. So that's not a concern. And then next slide, please. I'm going to go through these fairly quickly. The biggest thing is to try to encourage your states in terms of how you can advocate for individuals who are impacted, making sure that states take their time with unwinding. Unfortunately, some states are not, as Eric mentioned, some states have already agreed to committed to beginning review terminations this month. But if you have any leeway with your state partners and state Medicaid directors, making sure that states take as much time as possible. Initially, states had 12 months to complete all of these renewals. Now, the recent guidance has said that states must begin these renewals within 12 months, but they can complete them within 14 months. So there is a much longer timeline. And then encouraging states to deprioritize people with disabilities and older adults, who we sometimes call, who are often referred to as non-MAGI enrollees. And so what that means is MAGI is modified adjusted gross income. People who are on non-MAGI Medicaid, or again, usually older adults and people with disabilities, are the ones that have asset tests. And then they're usually individuals who are on fixed incomes. So they are, one, the predetermination process takes longer because they have to look at their assets. And then they're usually on fixed incomes because they're older or they're on disability or Social Security or SSI. And so there's not as much fluctuation that you see with the MAGI population where people could be working and not working and so on and so forth. So it makes a lot of sense for states to say, okay, well, let's put the pause there and focus on other folks whose eligibility changes may have happened. And then next slide. Another big one is ex parte reviews, which just means that states are determining eligibility based off of reliable existing data sets. So if someone's qualifying for a state housing subsidy, well, they already have that individual's family size and income and so on. So states could be relying on that or information from Social Security to determine eligibility, and then just send out a form saying, oh, just to confirm, is this it? Or let us know if this number is not accurate. Making sure that individuals are contacted by more than one modality before terminating coverage for return mail. So if there's an email address on file or phone number on file. And then the reasonable compatibility threshold is huge because that says that if you have these existing data sets and you can see from Social Security that someone is within, say, 10% of Medicaid income eligibility threshold, then they'll just say, okay, well, that's close enough in a, very, very basic way, is saying like, well, they're close enough to that threshold that the expenses that we'd have to do to try to determine their actual eligibility is not worth it, because they are very, very likely eligible or so incredibly close that we can just go ahead and have them renewed automatically. And then making sure that appeals rights are honored, including having a good time frame for appealing a termination notice. And then next slide. Transparency is huge, monitoring how things are happening, monitoring how people are transferred into other programs like Marketplace or Medicare coverage, including referrals to those programs, making sure there's a clear timeline for sending out notices, and then screening people who may be eligible for one of those Medicare savings programs. And then next, I'm going to actually skip that next slide and move to slide 24. Which is collaborating is really, really, really key. States as a whole have not been doing as much as I would like in terms of preparing people for this. And so relying on all sorts of partners in the aging and disability spaces is huge. I think that there's going to be a lot of people who are going to go to their pharmacist with their Medicaid cards, or expecting that their Medicaid card in the system will cover this prescription that they're getting. And then they find out like, no, it doesn't. And so really being strategic in who we're reaching out to, not just the usual suspects, but providers as well, is really, really, really important. And making sure people are aware that they will have to start updating information. And then that's it. The last couple of pages are just resources, many of which Eric alluded to as well. I will just add that the National Health Law Program also has really helpful guidance and materials for legal advocates, for other types of advocates as well. And then my email is on the last slide if you did have any questions for me. And I'm so sorry, I know we're butting up on the end, but I appreciate being here.
Yeah, no worries at all. Thank you. That was a great presentation. I know that it answered a lot of people's questions. I am not seeing any questions in the chat, but did want to turn things over to Eric super quickly. He had a follow-up point to make from his presentation.
Yeah, I just wanted to flag in a chat, and certainly hopefully people will put questions in there, but do want to follow up. I maybe said something that wasn't clear or incorrect. When talking about the required continuous enrollment for children, that does not actually go into effect until 2024. So children will certainly still have to go through the enrollment process, but again, do want to reiterate that there may be many children who are eligible for CHIP, whereas the parent maybe will be deemed ineligible for Medicaid. So again, super important that as people are getting these notices, they consider the eligibility for everyone in the household, but do want to sort of de-link those two concepts because they're not quite the same. Just want to make sure that was clear.
Yes, super important. Thank you for sharing that point with us, Eric. And thank you for doing a little research there on the break to come back and answer questions. I appreciate it.
All thanks to my team.
Awesome, guys. Well, I know that we have one quick update from Salone. Salone Salzberg is joining us from Horizon. So Salone, I will turn things over to you for your update.
Thanks, Caitlin. Hi, guys. I've done a couple presentations over the past couple of years talking about value-based payment arrangements. And so our coalition, the Council for Affordable Health Coverage, has been working on a bill called the Medicaid VBPs for Patients Act, or the MVP Act. And yes, I do go around the office calling myself the MVP for this. So basically kind of at its core, and I'm sure a bunch of you have heard this before, but that value-based payment arrangements for drugs are essentially when you pay if the drug works, and then if it doesn't work, the manufacturer has to give some kind of refund to the payer. And so it's really the goal of these is trying to make sure that we're getting the right drug to the right patient at the right time. There was a CMS rule a couple of years ago that tried to better enable these into Medicaid programs. So Medicaid, different state Medicaid programs had more capacity to enter, or more freedom to enter into these arrangements with individual manufacturers. And this bill was actually just introduced yesterday or the day before. My days are all getting mixed up. It's HR 2666, and it is a Guthrie issue. And then there are a handful of other bipartisan supporters, but mainly Representatives Guthrie and Eshoo. The Energy and Commerce Committee is actually having a hearing on this bill along with a bunch of other bills on Wednesday of next week. And so we are running a sign-on letter in support of that. We're reaching out to a bunch of members in the Congress or members of Congress at the federal level to show our support for the bill, and just wanted to highlight that for folks. So I'll make sure Every Life has kind of all of the links. We've got one-pagers on the bill, kind of just giving an overview of what the issue is, and then a link to sign on to the letter. And I'll have my contact information there if anybody has any questions.
Amazing.
Do that
Thank you.
quickly.
Nice and quick. Beautiful. Thank you, Zillah. As always, thank you to all of our panelists for joining us. This is certainly a very timely and important topic. I know that a lot of our advocates had a lot of questions about what the end of the public health emergency meant. So I appreciate you all coming to answer those questions and to clarify this all a bit for us. Our next webinar is going to be on May 18th. We are going to be focusing on the connection between mental health and rare disease. So I encourage you to join us for that. It will be at noon as always. And of course, please keep in touch with us. If you are not signed up for our newsletter, you can do that at rareadvocates.org. Again, the newsletter is just full of great resources. We do federal policy and state policy updates, free resources for the community, free events for the community. So definitely get signed up for that newsletter. It's great to just stay in the loop with everything that's going on. And then, of course, I encourage you to follow us on social media, again, just to stay in the loop with everything that's going on at the Every Life Foundation and within RDLA. And last but not least, thank you to our April RDLA webinar sponsors. And thank you to everyone for joining us today. I appreciate it, and we will see you next month. Bye, everyone.